just asked some rhetorical questions. How many of the primary care providers provide brief office counseling in their practices? And I want you to think about what are the barriers to providing brief office counseling for mental health problems as well as changing health behaviors. And then how many of you have a specific framework that you use? So the general public and many health professionals are unaware that the primary care sector has become the United States de facto mental health system for common mental health problems. In fact, primary care physicians provide most of the mental health care in the United States, more than half at least. And at least half of all professional visits for mental health are with primary care physicians, and up to 3/4 of prescriptions for psychotropic medications, mainly antidepressants and anxiolytics, are written by non-psychiatrists, with the majority being written by family physicians, pediatricians, and internists. Yet basic counseling procedures such as empathetic listening and collaborative problem solving are not well taught in medical school. In residency programs, the teaching and learning of basic counseling is quite variable. So I think because we do it so much, primary care physicians need to be able to provide effective mental health counseling in the context of the primary care visit. Most common symptoms presenting in the typical primary care office usually cannot be attributable to a specific organic cause. In one study during a 3-year period, of the 10 most common presenting complaints in primary care, fewer than 15% had a specific cause, suggesting that there's a significant role for psychosocial factors. And those common symptoms that they looked at are listed up there. So for example, depression is often coexisted with diabetes, and it's well known if you don't treat the depression, it's hard to get the diabetes under good control. On the other hand, the diabetes may have precipitated the depression because it's a chronic illness that's difficult to treat. In patients with irritable bowel symptoms in one study, if the patient had the coexistence of anxiety or depression or a fear of dying of cancer, they were less likely to seek care. So having coexisting illness can also impede one's ability to get their medical problems taken care of. Also, in a lot of the studies that look at the incidence of mental health problems, chart extraction data that's used to document the extent of mental health problems may actually underestimate the true extent of the problem. Physicians practicing primary care might not always document mental health problems or counseling that may have occurred during a complex visit. It's also well known that patients with mental health problems use more medical services for non-mental health problems than those without mental health problems. Up to 50% of so-called high utilizers of the health system have mental health conditions. Furthermore, providing mental health services reduces the use of medical resources by 20 to 40%. I want to repeat that. Providing mental health services reduces the use of medical resources by 20 to 40%. That's really interesting. And that's primarily through reduction in emergency department visits and unnecessary testing. Other groups of patients who have disproportionate healthcare costs include those with so-called lifestyle risk factors such as smoking, excess alcohol use, high-fat diets, and sedentary lifestyle. And physicians usually attempt to counsel patients to change long-standing habits, and the most common counseling method employed has been education about the long-term method and then advice to change it. For example, exercise for 30 minutes a day, at least 4 to 5 days per week, or you need to lose 15 pounds within the next 6 months. Unfortunately, physicians often report feeling their efforts have been ineffective with these problems because behavior change is difficult to achieve and maintain. Therefore, it behooves us to have a repertoire of counseling techniques at our disposal, ones that we're comfortable using. And so thinking about the obstacles in primary care, I hear a lot with primary care visits only lasting 20 minutes. One frequent complaint is I don't have time to do that. Many primary care visits are also complicated by multiple problems. Many folks have many different things to do during those visits. More than 2/3 of primary care visits have more than one medical issue. and half of all primary care visits have a new problem. Additionally, more than a third have an administrative issue. For example, can you complete this FMLA form while I'm here? Furthermore, primary care physician reimbursement for mental health has been traditionally pretty poor. So even when a mental health referral is made, up to 50% of patients do not keep the initial appointment, implying that patients are more likely to talk to their primary care physician about their mental health problem than going to another provider. And a lot of people, like the case that was just presented, are concerned about the stigma. They also might not be open to believing that the doctor sees their symptoms outside of something a normal primary care doctor should be able to take care of. So a whole host of issues might go through a patient's mind when you refer them to a mental health provider. And physicians themselves often say they would like to do more counseling with their patients, but they are already struggling to fit in complaints into a 20-minute visit. And physicians also fear, as I do, that if you open up the questions, you might not know what to do about it. So now you have a patient that you've figured out that they have a distress that going back to an event from 15 or 20 years ago, and the patient doesn't want to go to a mental health physician, and you've opened Pandora's box. So let me see here. A key challenge, therefore, for primary care physicians is adopting psychotherapeutic techniques in the time-limited, multi-problem primary care context. So what I want to share with you today is a couple of different approaches that have been proven to be helpful that can be done in a brief time frame. These include the BATHE technique, the FRAMES brief intervention model, adaptation of the trans-theoretical stages of change model, and a brief motivational interviewing. And then we're going to finish up a little early, and Russell is going to perform some motivational interviewing on me so you can watch that and solve some of my behavior problems. So we're going to start with the BATHE technique. This is an approach to counseling patients on psychosocial issues that was developed by a psychologist and a family physician specifically for primary care. So BATHE is an acronym for a sequence that physicians move through addressing specific issues that build on each other. The 15-minute hour, which is a book here, this is the third edition I'm holding up. Can they see this? I don't know. This is the third edition. There's actually a fifth edition out now. And in this, the BATHE technique is described in detail. A BATHE interview often requires less than 5 minutes with most patients, and with others, even less than 1 minute. The original authors suggest that the technique can be used with all patients, but many physicians reserve the BATHE technique, as I do, for conditions in which there's a psychosocial conflict that might be a contributor to a specific diagnosis, such as tension headaches, for example. For the physician on a tight schedule, a mental problem background can be daunting. Clinicians might feel that they can't adequately understand the problem without delving into, at length, a patient's history. But by following several principles, which I'm going to point out, physicians can prevent the background segment from becoming overly time-consuming. There are several misconceptions about understanding the details of a patient's problem. First, a common myth is that the more the patient talks about the problem, the better able the primary care clinician will be able to understand and help. That's actually not always true. While a certain level of important detail is necessary for the primary care physician, there rapidly becomes a point of diminishing returns in obtaining more background information. Once a pattern of non-essential detail and rehashing the same problem becomes apparent, the physician can structure the exchange through several strategies. For example, I like to say, I understand that you are really worried because you found a bag of something that looked like cocaine in your son's jacket. You don't want to turn him over to the police, but you know he could get in serious trouble if he continues with this path. So a gentle interruption and refocus of the patient by saying, I think I've got a handle on the problem and why it's so important to you can be helpful in bringing them back in when they're getting into details. Frequently, the patient and physician become overwhelmed when escalating details of the problem become apparent. So in contrast to the psychotherapist's request, tell me more about that, the primary care physician seeks to keep the problem time-focused and manageable. Moving on to asking the patient how she feels about the problem appears straightforward. However, many patients can get bogged down in factual details. The physician might ask the patient to refocus by saying something like, "I have a good handle on the difficulty you're having with your son, but how do you feel about it?" People tend to somaticize their psychosocial distress, but may have difficulty in describing their emotions. Patients who are coping with the crisis through denial may have less access to their affective feelings. So you can suggest some adjectives to help emotionally restricted patients express themselves. For a patient whose husband has suddenly left her after a 15-year marriage, terms such as angry, hurt, lonely, overwhelmed, sad, and so on might be suggested. Patients who have difficulty verbalizing feelings, the physician might be able to infer their emotional state through their body language and make some suggestions based on that. Focusing the patient based on the most troubling aspect of the situation makes the problem manageable. A common objection to this approach is that it might seem to reduce a major life event, such as the death of a patient, to an artificially narrow issue. However, it is easy for both the patient and physician to become overwhelmed by the magnitude of psychosocial problems. Asking the patient what is troubling her most about this helps direct the physician to assist the patient in examining how she might respond to a particular crisis at hand. By asking how they are handling a particular stressor, the physician can quickly assess coping skills. Additionally, the physician can inquire about possible actions the patient might take and the likely consequences. In response to a patient saying, and this might sound like an exaggeration, "I'm going to kill my husband for cheating on me," the physician might respond, "What would happen then?" And the patient might respond, "Besides him being dead, I would have to go to jail." So these can be useful questions to ask the patient to consider what would be the worst thing that could happen if you carried out what you're thinking about doing. So what you're doing by asking that is encouraging the patient to consider possibilities and consequences on her own. Increased alcohol consumption, drug use, cigarette smoking, or overeating by the patient suggest poor coping skills. Finally, conveying empathy is pretty straightforward, I think. By communicating that the physician understands the patient's emotional difficulty, you're providing support and validating the patient's experience. Moving on to the FRAMES model for health risk. FRAMES is a protocol originally developed to address objective health risk behaviors such as alcohol abuse. However, it can be readily applied to problems such as smoking and chronic disease management behaviors. In using the FRAMES feedback, responsibility, advice, menu of strategies, empathy, self-efficacy, the physician begins with objective feedback regarding personal risk. For example, for alcohol use, liver function tests or blood pressure readings could be used. For smokers, upper respiratory infections or recurrent upper respiratory infections could be used. So for feedback, explaining the relationship between the health behavior and the abnormal test or the upper respiratory infection is helpful. For the responsibility of the patient, it is useful to make a statement such as, "You have the ultimate control over your drinking," and allows the physician to emphasize that the decision to change has to come from the patient. Regarding advice to change, it's important to give a clear message. For example, "For your health, I strongly recommend you cut down on your drinking." Under menu of strategies, the physician can provide pharmacotherapies, advice to avoid high-risk situations, etc. Here, the purpose is to emphasize patient choice and the responsibility for the change, again, being on the patient, and then helping the patient select the strategies that they think will be most successful. Under empathetic style, you provide emotional support and finally promote self-efficacy. You sound like you have a solid plan to cut down on your drinking, your health and family seem to be very important to you, etc. So what I like about the FRAMES model is that it emphasizes the responsibility for change rests with the patient. The physician can suggest, but the patient has to be the one to decide what to do about their drinking. However, many patients might experience these assertions as confrontational. So if you say something like, "What you decide to do to your drinking is up to you," that might seem confrontational to some patients. So a more productive way that I like to do it is to say, "Now that we've talked about that, what are your thoughts about how to get your blood pressure under better control? Or what do you think about your need to cut back on alcohol use?" Then you can assess where they are kind of in their thinking, and this can be combined sort of a stages of change model, which we'll talk a little bit more in a minute. Patient's acceptance extends to, getting them to accept that might cause some internal struggles with cravings and emotional struggles that they might have with substance abuse, and often people describe their drug of choice as their best friend and this sort of thing. So advancing patient self-efficacy requires the patient to commit to a balance between optimism and realism, and physicians should always inquire about patient goals and negotiate an endpoint that is likely to be achieved. For example, if the patient who weighs 260 pounds says, yeah, I want to lose weight down to my high school weight of 150, this is likely to be an unrealistic goal. So telling the patient that a 10% weight loss that you keep off forever has proven benefits, you'll feel better and you'll lower your risk might be helpful for the patient. Moving on to stages of change model. So I think everybody's heard of the stages of change model. And what this just says is, as a physician, understanding where a patient is in the continuum can be helpful to match your advice to the patient's readiness for change. So in the pre-contemplation phase, questions like, what do you like about smoking, or what keeps you drinking every day, or future-oriented questions like, how long do you think you will keep smoking? You heard earlier when we were talking about the patient, what does he want? What does he want for the rest of his career, and this sort of thing. That way you can kind of create the dissonance between what they're doing and what they want to be doing down the road. In pre-contemplation, the physician provides a factual statement about the health effects of smoking. What do you think of that? Asking the patient, and then moving on if they're not ready for change. In contemplation, the physician encourages the patient to consider the pros and cons of changing, as well as looking at their readiness for change. What will you do in a high-risk situation to prevent relapse, for example? How can you prepare for it, and these sort of things. In the action stage, when the patients have quit and they're in the process of quitting in the first couple of weeks, maybe first 6 weeks, asking about unforeseen obstacles and lapses. How is your plan working? What challenges have come up that you didn't expect? And if they've had a lapse, how do you get them back on track, trying to prevent a full relapse? And then in the maintenance phase, most people have had some relapses between the day that they quit and when they get to maintenance. Use relapse and lapses as learning experiences. What happened that caused you to have that cigarette that one time? What helped you to get back off the cigarettes? And then what are you going to do if you have a bigger stressor next time? So, and then moving on to our final, which is the motivational interviewing. And we're going to have about 10 minutes left to do a little bit of that. I think most people have heard of this, but using it well, it can be challenging. I think the physician using MI has 4 tasks. 1 is quickly develop an empathetic, supportive collaboration with the patient. 2 is highlight a discrepancy between the patient's health risk behavior and another strong personal value. 3 is avoid arguing, cajoling, or lecturing the patient. I list that as a specific goal when they're resisting change. And 4 is focus on the patient's strength and supporting their efforts to change. So key components: expressing empathy, conveying an understanding that habit change is difficult and ambivalence about change is normal, finding common ground with the patient, and assuring the patient you will not be critical. And then developing a discrepancy, which we've tried to do in the case that was presented today. I think Russell really suggested eliciting the patient's important values through questioning. I think Nicole was talking about, well, is having your family close to you and that sort of thing important to you? So you might be able to create a discrepancy there. The important thing is to create a dissonance that the patient must resolve by recognizing that if they don't change their behavior, that dissonance will remain. And then rolling with resistance, not arguing with the patient. Purpose is to emphasize patient responsibility and your partnership with them. And then finally, supporting their self-efficacy, supporting the patient's belief that he can change, for example. An example of a 63-year-old grandma who smokes 2 packs a day who comes in complaining of not being able to keep up with her grandchildren, you've got the perfect dissonance already set up there. So you can take the valued relationship and then kind of develop that into making a behavior change model that the patient can recognize. Similarly, in a patient who's pregnant, who's drinking, there is already a dissonance built up for you there. It's just a matter of recognizing it. I'm a caring mother who would never harm my baby. So then you can kind of create that, have the patient figure out that there's something that doesn't match up there, and then have them be the agent of their own change. So what I want to emphasize is that research has shown these models to be effective. For example, in one study, they randomized teenagers using cannabis to two groups, and one got the frames applied, and they showed a statistically significant reduction in cannabis with none in the control, no reduction in the control group. The models are easy to apply. In one study in a busy practice, they were able to show using the, I believe it was the frames model, took 3 minutes for smoking cessation, 5 minutes for problem alcohol use, and 8 minutes for fat and lipid levels.
That's different than I would think.
Yeah, but it takes practice. Obviously, the first time you do it, like anything, but if you pick a model and one or two of these models, and I like the BATHE myself, and then I'm starting to learn motivational interviewing. I say starting. I've been starting to learn MI for about 8 years, but when I hear people like Russell do it, I'm like, wow, I wish I could do it like that. But he's practiced a lot more than I have.
I think he just speaks MI in all of his language.
Yes, agreed. So I have asked Russell to conduct a brief motivational interviewing session with me as the patient. So the background is having hyperlipidemia and obesity and not having lost any weight since the last office visit of 1 year ago, and when we agreed to lose 10 pounds by the next time.
Okay. So I'm going to do this. I'm going to act as if this is the last 5 minutes, because we're going to try and demonstrate you can actually do this quickly. So Dr. Baltry, again, I'm glad we got your paperwork all completed. We have about 5 more minutes. Would it be okay if we use that to talk a little bit about some of your weight-related goals that we had last time?
Sure.
Okay, so you're good with that?
Oh, yeah.
So tell me, how do you think the past year's been in terms of your diet and in terms of, we'll start with your diet. How do you think it's been in terms of your diet?
Up and down. I mean, I did stop eating bread and pasta, so that was good.
My gosh.
Yeah.
That's awesome. How were you able to do that?
I do it probably 90% of the time. I'd say when we go out, sometimes I don't always follow that, but you know, most of the time we just cut that out. I got an agreement with my wife to cut out wheat and that sort of thing.
So that kind of like that support, that connection to your wife, and it helps with that. Okay. So it sounds like you feel like you're pretty successful in that way. How do you think otherwise? How do you think that you're doing in terms of your weight and your diet?
The weight's not where I want it to be.
Okay.
And I think the diet is, I just haven't been exercising as much as I was before.
Okay. So are you thinking then that the diet's pretty good? And I just want to, again, congratulate you. A lot of people struggle with the changes that you've made. So good for you.
Yeah.
But the diet, the exercise, you feel like is kind of like the priority right now?
Probably need to get that higher, yeah.
Okay. And what makes you say that?
Because I don't do enough.
Okay.
I do walk every day about 2 or 3 miles, but I don't get the aerobic exercise in that I need to.
Okay, so that's, I just want to acknowledge too, that's really good. A lot of people have a hard time even doing the walking. Tell me about a time in your life when you were exercising regularly.
A couple of years ago, I was exercising regularly. Then I took on more stuff at work. But really, that's just an excuse because there's time at night to exercise, but I just haven't been motivated.
Gotcha. How did you feel when you were exercising regularly a couple of years ago?
I felt pretty good. I had more energy.
Okay.
Yeah.
So you were more energized. You just felt better about yourself.
I did, yeah.
So you mentioned that sounds like you're busy, and it sounds like, part of where you would be trying to do exercises at night.
Yeah.
What's been getting in your way? Like, what's kind of good about not exercising at night?
Just being lazy and sitting around and hanging out with the pets, the dogs and stuff. And there's really not a good excuse, honestly.
It seems like you work hard and you come home and you just kind of don't want to feel like you're working anymore. You just want to chill and enjoy your time.
Right. Yeah.
Okay. Any other things you think get in your way of doing any exercise at night?
Not too much. It's pretty much motivation.
Okay.
Yeah.
What do you think would be some benefits to you to doing a little bit more exercise when you come home at night?
I think I would feel better, probably have more energy the next day, probably sleep better.
You've mentioned energy a few times. What would having more energy matter in your life? What would it add to your life?
I think I'd be better able to focus and probably actually accomplish more.
Okay. So it may even be more effective in your professional and personal life. Okay.
Probably.
Okay. So I get it. Like you're on the fence a little bit. And again, I just really want to acknowledge, like you've already made a lot of changes and that's good. So it shows you can do it. It shows how much you care about your health. On the one hand, you don't want to exercise because it's just kind of time for you to relax, be kind of lazy, you work hard, you kind of give yourself that at night. And on the other hand, you feel like that if you exercised, you would lose this rest of this weight you want to lose, this 10-pound goal. It'd improve your health. You feel like you'd be more energetic, and that might even help you be kind of more effective. How do you know when you think about that kind of dilemma, what do you think is the right direction to go from here?
I just need to get started.
Okay. So what is a step that you think would be possible, but would be a stretch goal for you in this direction? Let's say over the next couple of weeks.
A stretch goal would be probably getting on the treadmill 4 times a week for 30 minutes.
Okay. So you think that would be something you could do and that would be be a benefit to you?
I think so.
How do you mentioned before that your wife seemed like she kind of supported you with the bread and the grains. So maybe it's not her, but what do you think could support you when you get home and you kind of don't want to do it? How might you talk yourself into it at that point, or what might help you?
Probably just keeping a diary.
Okay.
Yeah.
Okay.
Writing it down, making a commitment.
Okay. So would that be the kind of thing you do it like beforehand? Like you'd look at your week and you'd say, I'm going to do it on Tuesday night and Thursday night. Okay. So what I'm hearing is that what you like to try and do over the next 2 weeks is write in your diary, like your goal of the 30 minutes on the treadmill for 4 days a week. You'll figure out the 4 days and kind of try that for 2 weeks. So we've got a couple minutes left. So how will you talk yourself out of that?
Well, if I have a late meeting and I don't get home till 7, I probably wouldn't do it.
Okay.
But if I use the diary, I usually know in advance what nights I have a meeting, so I could not plan it on that night, probably another night.
Perfect. So it seems like you can kind of schedule your way out of that one way that you might talk yourself out of it.
Yeah.
So on a scale of 0 to 10, how confident are you that you're going to leave here, you're going to get in your diary, you're going to write down 4 times, which would be 8 times over the next 2 weeks, and commit to that? 0 means not at all confident, 10 really confident.
So I'm a 10 on committing to it. I'm an 8 on doing it. On actually doing it. I'm sure I'll start, but I'm not positive I'll get 8 times in the next 2 weeks.
Okay. How come you're at 8 and not like a 5 or a 6 in terms of doing that 8 times?
I feel really good about this conversation, actually, so I appreciate the support.
Hey, I appreciate all you've done. You've done a lot. So would you be open to coming back in 2 weeks and we'll just kind of see what happened, see how you're doing with it?
Sure.
Okay. All right. Thank you.
Thank you.